structural changes in the sacroiliac joints, and stage 3 with structural changes in the spine. Actually, there is a delay throughout the world, not only in underdeveloped countries, but also in developed countries, of 7 to 9 years in diagnosis. And this is related to the fact that radiographic changes on plain films develop at least 5 years after the onset of symptoms, plus some delay in the general practitioner, plus some delay in the orthopedic surgeon who is not giving too much attention to the clinical symptoms. Then we have a significant delay in diagnosis. So spondyloarthritis principally involves the enthesis, in contrast to inflammatory arthritis, which I suppose it will be addressed later in the next lecture, which involves the synovium. And what is enthesis? How we define enthesis? Enthesis is the insertion point of tendons, ligaments, and articular capsule, and this is considered nowadays as an organ rather than an anatomical location. There are some joints, like the sacroiliac joint and the acromioclavicular joint, who have also some synovial part, but they are behaving, clinically speaking, as enthesis, and therefore they are called functional enthesis. So let's see an example. For instance, the anterior longitudinal ligament enthesis here in the anterior part of the vertebral body. The initial inflammatory lesion here results in the erosion of the bone. We see the erosion, and there is a subacute or chronic inflammatory reaction here, which is called osteitis. Then this erosion is healed with new bone formation, the so-called enthesophyte, and this is a new enthesis. The most important and the cornerstone for diagnosis of spondyloarthropathy is the presence of sacroiliitis. And perhaps the sacroiliac joint is the most difficult to image, as Anne Brouwer has said in her textbook. So today we'll discuss 4 topics. First of all, why the impact of imaging in the clinical management of patient is very important. Second, which is the current use and the current limitations of plain X-rays. Then, to recognize and increase confidence in depicting the MRI findings in chronic adaptive access spondyloarthropathy. And I would like also to present some mimickers in order to avoid any misdiagnosis. First of all, why it's important to image the access spondyloarthropathy? It is important because during the last 15 years, we have new treatments which have changed the management of this entity. And it has been changed with the anti-TNF medications. But these are very efficient if we pick up the disease in the very early stages, before radiological findings. That's why early diagnosis is important, and the role of radiologists is very important. This slide here is very important to remember because it's the official, let's say, instructions from the International Society of Assessment of Ankylosing Spondylitis. This is what rheumatologists follow. This is what we should also know in order to communicate with rheumatologists. So, with the ASAS criteria, the access spondyloarthropathy is suspected in patients younger than 45 years who have more than 3 months of back pain, which is inflammatory. That means it's morning pain and stiffness, which goes away or improves later on, and also it's a pain with no sciatica and no response to analgesics. So we need, in order to make a diagnosis of access spondyloarthropathy, to have sacroiliitis on imaging and one feature, at least one feature of all these, for instance, Crohn's or ulcerative colitis or elevated CRP or positive HLA-B27. This is the one diagnostic group of criteria. The second one is the HLA-B27 positive, but at least 2 of these features. So as you see, imaging is more important than HLA-B27, which has been used for decades in order to assess the seronegative spondyloarthropathies. And what is actually sacroiliitis on imaging? It is either a positive MRI, which we'll discuss later, or a positive radiograph, which we'll discuss in a minute. So, in order to make a diagnosis of non-radiographic axial SpA, that means the plain films are completely normal, we need to have these two groups of criteria. But as you see here, the HLA-B27 with at least two features shows a sensitivity and specificity which is equal to MR imaging alone. And when we combine MRI with at least one feature of spondyloarthropathies, we have an increased sensitivity and specificity and overall accuracy. Therefore, imaging is the most important part of the diagnosis. So the second part of this lecture is to treat the plain radiographs regarding their current role. It's a low-cost examination, is widely available. It's the first-line one, but we don't have to repeat them every year or every 6 months, because as we told previously, we need 5 years after the onset of symptoms in order to have lesions. We'll see which are these lesions. It's useful in monitoring the disease, and all we need is the so-called Ferguson's view. The Ferguson's view is an AP with 30 degrees cranial angulation. Unfortunately, plain film has a low sensitivity for early disease. That's why we moved to MRI. So what we need to know regarding the plain films is that there is a wide variation of the joint space width. Therefore, in each patient, we need to compare the width on the right side to the width of the left side in the same patient. The joint space width should be uniform throughout the course of sacroiliac joint, and the most important thing to do when you are in front of a plain film is to follow with a thin pencil. That's why I induced here the laser pointer, to see if this white thin cortical line is intact. If it is intact, then the sacroiliac joint is normal. We see here that we can follow throughout the whole course the thin cortical sclerotic line. So what are we looking for in a film? We are looking for the joint space width, as we mentioned previously, if it is bilaterally the same. We see, for instance, here we have an increased joint space width here as well. We look for erosions. Here is an erosion, a large one. Subchondral sclerosis. Here you see the subchondral sclerosis. And the presence and the type of ankylosis. Ankylosis is fusion, normal bone marrow crossing the joint. Here we see a partial ankylosis in this area. Another example, what are we looking here? We see that the sacral sided cortex is intact. We can follow this thin sclerotic white line. On the other side, we have an erosion, also a pseudo-widening because of the presence of erosion, and subarticular sclerosis. These are the findings that we expect in spondyloarthropathy. So according to the modified New York criteria, which were published from the ASAS, we have a positive radiograph for sacroiliitis if we have bilateral grade 2 or more. Grade 2 means erosion or sclerosis without involvement of the joint width, or unilateral grade 3 or more. 3 or more means erosions, sclerosis with widening or narrowing or partial ankylosis. And grade 4 is total ankylosis, which is reflecting a long-standing disease. So here we have some grading. Grade 1, there are suspicious changes. There might be here some sclerosis, but we are not very confident. In grade 2, we are confident. We see that there is sclerosis subarticular. There is also an erosion here. There is an erosion there and there. And here we have definitely sclerosis with some partial ankylosis. And here we have total ankylosis, therefore it's grade 4. So grade 2 bilaterally or grade 3 unilaterally cover the criteria suggested by the ASAS. You don't need to proceed to MR if you have this criteria. So, time for a break. Here I have a quiz for you. I incorporated the workshop into the lecture so that it can be more, let's say, educational. We have two patients here, 55 and 63 ladies, with almost the same findings as you see. There is some sclerosis, more on the left here, sclerosis bilateral here. Is this osteitis condensus ilii? Is this inflammatory sacroiliitis or degenerative sacroiliitis? Please vote. So, very well. This is not working. Okay. Most of you suggested the correct diagnosis. This is osteitis condensus ilii. May I go back to the lecture, please? Thank you. As you see, usually this is asymptomatic, but in a minority of patients we may have some low back pain. Usually it's seen in multiparous women. And the main differential diagnosis is inflammatory arthritis. So why did you diagnose here condensus ilii and not inflammatory sacroiliitis? I suppose that you show that the sacroiliac joint itself is intact without any erosions, without any widening, and without any ankylosis. This is the point here. If we don't see erosions, if we don't see widening or narrowing, then the sclerosis alone, together with the fact that the ladies were, as you see, 55 at 63, not younger than 45, as the ASAS criteria suggest, this is the correct diagnosis. Very well. So here we have the second case, 38 male, that means younger than 45, with 2 years of inflammatory low back pain. Please vote. Very well. 100% correct. 2 radiologists. Okay, thank you. Can I go back to the lecture, please? That's the correct answer. Here we do have some widening, as you see here, narrowing here. We have some erosions, we have some sclerosis, and this is bilateral, perhaps with some minor ankylosis here. Therefore, the symmetric appearance is suggestive of ankylosing spondylitis. Case 3, 2 different patients, both younger than 45, with inflammatory low back pain. Please vote. Okay, this time I think you are not in a good shape. Let's go back to the lecture. Actually, in these patients, we do have a bilateral asymmetric appearance. For instance, since we see here erosions, it cannot be condensers ilii. Here we see erosions, we see ankylosis, therefore it's not a good diagnosis, the condensers ilii. In this patient, we have ankylosis on the left, erosions and sclerosis on the right. That means asymmetrical involvement. And in this patient, we have erosions and sclerosis on the right. You see here erosions, and here, and sclerosis, but more intense on the left. This is psoriasis, and this is reactive arthritis. Therefore, to discriminate asymmetrical bilateral involvement, it's mission impossible. We have to differentiate, we have to include in the diagnosis both of them. Okay? So some tips for you. If we see unilateral involvement with florid, very intense, edema and enhancement, then this is almost always infection. If we have bilateral symmetric, it's ankylosing spondylitis, as we mentioned in the previous case, but this can be seen also in inflammatory bowel spondyloarthropathy, of course, condensers ilii, and also CPPD, which is rather rare in the sacroiliac joints, and bilateral asymmetric psoriatic arthritis, as we have seen, reactive, also gout and osteoarthritis at condensers ilii. I have a fourth case for you, which is the grading here, because the most important fact that we need to be aware of is to answer to the rheumatologist's question, which is the grade? If it is grade 2 unilateral, then we do not have the criterion. Please vote. Three. Only one answer, but this answer was correct. Thank you very much. So what we see here is sclerosis, erosions, partial ankylosis, not total ankylosis, so it's bilateral grade 3. What else do we see here in this plain film? Do you think this is normal? Definitely not. And there is also here, there is some enthesophyte. This is new bone formation and suggests hip involvement. And what else do we see here? We see sclerosis and early erosions here, tiny erosions in the pubic symphysis, suggesting also involvement. So axial spondyloarthropathy is not only involving the sacroiliac joint, we have to look also for the pubic symphysis and the hip joints in a plain film. So this is the last case regarding X-rays. I'm showing you a lady, 83, and you have to choose between degenerative sacroiliitis and chronic ankylosing spondylitis. Please vote. Okay, 4 of you suggested degeneration and 1 chronic ankylosing spondylitis. Let's go back to the case. The lady is 83 what we see here is that there is an anterior bridging. You see an osteophyte, and also there is ankylosis. What you need to remember is that anterior bridging osteophytes are always seen in degenerative osteoarthritis, and ankylosis is a normal finding in the elderly. It's not something that we need to match with a long-lasting ankylosing spondylitis. Okay, let's go now to the plain films of the spine. In the spine, the incisions have two locations. One location is at the area where we have the anterior and the posterior longitudinal ligament. That's the insertion of the ligaments, also the lateral ligaments. But there is also another incisus, which is the interface between the disc and the end plate. So in axial spondyloarthropathy, we do have two locations. One is inflammation at the insertion of the ligaments, and one is inflammation at the interface between the disc and the end plate. So in the ligament insertion, you see here an erosion. This is called Romanus lesion. The Romanus lesion is seen in about 2/3 of cases. And in the chronic lesions, we have repair of the inflammation of the osteitis. We have these sclerotic lesions, and this is called shiny corners. In the Anderson spondylodiscitis, that means in the area where we have the other location of the incisus, we may have extensive sclerosis, and this is called aseptic spondylodiscitis. Non-septic, non-infectious. Sometimes radiologists or orthopedic surgeons consider this as possible infection and move to image-guided intervention for diagnosis, biopsy. We need to be careful. Anderson spondylodiscitis may look like much the same like aseptic, infectious spondylodiscitis. So in this patient, we see that the sacroiliac joints are gone, and this also they are gone, but also we see that there is a sclerotic line here. This is ossification of the posterior interspinous ligaments, and it's called the Dagger sign. Another sign is the so-called trolley track sign. Here you see that there is a sclerotic line representing the ossification of the facet joints. The Gauss sign reflects the fact that we have no sacroiliac joints. They are fused, as you see here. And the Babu spine represents the ossification of the lateral ligaments. In long-lasting disease also, we may see ballooning of the discs, or calcification in the discs, or anterior fusion, as you see here, ossification of the anterior longitudinal ligament, and here we see calcifications. Let's move now to MR. The third topic. MRI now is considered to be the method of choice. The technique is very easy. We need a sagittal T2, and then we plan an oblique set of images, oblique coronal and an oblique axial perpendicular to the previous one. We need to have always an oblique coronal T1, and we need to have two fat-suppressed sequences. I usually apply both stir and fat-suppressed PD or T2. I need to have different physics in order to get rid of any possible artifacts. So I suggest for you to use T1 in oblique coronal, stir oblique coronal, and fat-suppressed axial, oblique axial images. In case that we inject contrast, we need both planes. So the normal sacroiliac joint on T1 shows the thin sclerotic lines that we know from the films. These are low signal intensities, uniform width, and what we look for on T1 is sclerosis, erosions, fat infiltration, and ankylosis. All of these findings represent structural changes. That means chronic axial spondyloarthropathy. Okay? T1, chronic. Fat-suppressed images, active changes. And here we are looking for one single finding, and this is called bone marrow edema. So if you don't have any bone marrow edema on both sides of the joint, then this examination is completely normal. So may I just remind you that the sacroiliac joint is a rather complicated joint which has both a synovial part anteriorly with hyaline cartilage and fibrocartilage and a ligamentous part posteriorly. But regardless of the synovial or the ligamentous part, the ASAS criteria require at least 2 bone marrow edema lesions in 2 consecutive sections or 2 lesions on the same section. This is what we are looking for. This is the criterion that you need to report to the rheumatologist, that I see 2 foci of bone marrow edema, and therefore we fulfill the criteria by ASAS, and this patient has axial spondyloarthropathy. Okay? Here we see the location of the area of bone marrow edema changes, subarticular in the synovial part and also in the ligamentous part. Oh, may I say also that any other finding like synovitis, capsulitis, enthesitis, all the chronic lesions do not fulfill the criteria of ASAS. And why are these criteria so strict? The fact is that the anti-TNF treatment has a cost of about 1,300 euros or $500, $1,500 per month. And also they have adverse reactions. Therefore, we have to be very careful in which patients we are going to provide this very efficient treatment. That's why these criteria are very strict. So here we see bone marrow edema. We have one area here, one area there, and the third one here. Therefore, we have the criteria of ASAS fulfilled. And this patient, we have 2 areas of bone marrow edema on the same image. Therefore, this examination is positive for axial spondyloarthropathy. This is the cornerstone of diagnosis: bone marrow edema in the subarticular area. Another patient, 17 years old, you see extensive areas of bone marrow edema on both sides of the joints. And in another patient, 33-year-old, we see on one side, and also we see enhancement of the ligamentous part and the synovial part of the joint. This enhancement is not one of the criteria. It's only the bone marrow edema. So the presence of bone marrow edema on MRI usually is seen a couple of weeks after the onset of symptoms. Therefore, this examination is very sensitive, is very accurate, is the method of choice. So I have a case for you now. 17-year-old male. There is a history of juvenile idiopathic arthritis when he was 5 years old. And now you have to choose between axial spondyloarthropathy, rheumatoid arthritis, and infection. Please vote. Needless to say here that the plain radiographs were completely normal. Okay, it's reasonable to think that rheumatoid arthritis might be, let's say, a rebound of the juvenile idiopathic arthritis, but rheumatoid arthritis in the sacroiliac joints is quite rare. We need lots of fluid at synovitis, whereas in this particular patient, we have only bone marrow edema, and most of you suggested the correct diagnosis. Let's go back, please, to the case. Here you see that there is extensive edema throughout the subarticular area. There is also a small focus of edema here on the sacral part, also there. But in general, we don't see many structural changes with the exception of this small erosion here. So the chronic inflammatory lesions that suggest that there was an inflammation are the sclerosis, erosions, fatty deposition, and ankylosis. So on T1, we are looking for these 4 signs. We are looking for sclerosis. Sclerosis are low signal intensity on all pulse sequences. They are more remarkable on T1 because we have the high signal intensity of the surrounding fat. This typically extend more than 5 millimeters from the joint surface. So sclerosis is one chronic finding. The other one is the presence of erosion. Here you see an erosion. It's a bony defect with low signal intensity on T1. And when we have many erosions, then we have a pseudo-widening of the joint. This is the fatty infiltration or fatty replacement. This occurs following a previous inflammation. As you see here, there is high signal intensity on T1 in the immediate subchondral area because of previous inflammation. Ankylosis also reflects a long-lasting disease. Here we see that there is no joint space actually, and if you see carefully, you will see that this disc and this disc as well has been ossified. Therefore, we have fusion of the lower vertebral bodies as well. So these are chronic changes. What about gadolinium? There is a long discussion in the literature if we need gadolinium in order to increase the accuracy of MRI with respect to the diagnosis of axial spondyloarthropathy. When we do have old and active lesions, I think that this is very useful. For instance, here the gadolinium shows very nicely the capsulitis. Capsulitis is defined as the inflammation of the anterior synovial capsule of the sacroiliac joint, which is here enhanced. In addition, we see the bone marrow edema, which is diagnostic of the active lesion. We see also bone marrow edema in the pubic bones, but there is something else that we also see. We see edema at the insertion of the adductor ligaments here and tendons, and we see also edema at the ligaments posterior to the left sacral wing. This is enthesitis. Enthesitis, it is better seen with gadolinium injection. Do we need to see enthesitis in the context of the diagnosis? Because it's not included into the criteria. Yes, we need. Because in some cases, the bone marrow edema is not very bright. They are borderline cases. And if we see capsulitis, enthesitis, then we easily suggest that this is an ankylosing spondylitis. So here I have a case for you. We see a 33-year-old female with a pain lasting for 8 years, inflammatory pain in the back. Is this osteitis concedens ciliae or acute and chronic lesions in axial spondyloarthropathy? Please vote. Okay, thank you very much. That's the correct answer. We do have acute and chronic lesions in axial spondyloarthropathy. What we see here is sclerosis on T1 and fatty replacement on T1. These are the two findings of structural lesions, chronic lesions. We have a third one also. You see here an erosion, but T1 is not able to pick up the bone marrow edema. Here we see that this lady has bone marrow edema, extensive on both sides of the sacroiliac joints, and therefore we have acute and chronic lesions. And after 3 years of treatment with anti-TNF, you see that there is no bone marrow edema. There is no active lesion in keeping with the clinical improvement of this patient. So, as an overview of sacroiliitis in axial spondyloarthropathy, what you need to know is the criteria suggested by ASAS, and you need to look for bone marrow edema. If you see at least 2 areas of bone marrow edema, you can suggest the correct diagnosis. Otherwise, the chronic lesions or the rest of acute lesions are not included in the ASAS criteria. Let's move now to the spine. The spine can be involved after the sacroiliac joints, but in some patients we can see involvement of the spine before the sacroiliac joint involvement. And the findings of early active axial spondyloarthropathy are similar to the ones that we see in the sacroiliac joint. So spondylitis is the osteitis, therefore it's the bone marrow edema. The spondylodiscitis of Anderson's, which is not included, of course, in the sacroiliac joints, we may see arthritis and we may see also enthesitis. So I'll show you some examples in a minute. So the spondylitis reflects the osteitis at erosions at the site of insertion of the ligaments, and this is very interesting that if we see bone marrow edema at the ligamentous insertion, we know that without treatment we will have syndesmophytes 2 years later seen on plain films. That's why MR imaging is the method of choice. Let's see now the real life of axial spondyloarthropathy with spinal involvement. You see T1 low signal, T2 high signal. This is the osteitis. This is the same as in the sacroiliac joint, and this is called Romanus lesion, which is seen in 2 out of 3 patients with spondyloarthropathy. Therefore, it's the initial inflammatory reaction at the ligamentous insertion. The Anderson lesion, now it's called by most of the authors and the people who are involved in this group of disorders as aseptic spondylodiscitis. It is seen in 1 out of 3 patients with axial spondyloarthropathy, and we need to have at least 2 adjacent levels of involvement. Here you see such an Anderson lesion, another one here. It looks like acute small, but acute small that high up in the thoracic spine is impossible. So all these are Anderson lesions. We may have also both. Here you see Romanus lesion and Anderson lesion. The percentage that we see both of them is not well known, but they are highly suggestive of axial spondyloarthropathy. The chronic lesions here are more or less similar like in the sacroiliac joints. We have syndesmophytes, which are the end result in the healed erosion with new bone formation. We may have ankylosis and fat deposition in the way that we have fatty deposition in the subarticular area in the sacroiliac joints. For instance, here you see that there is a fusion. There is no disc. The disc has been ossified. In this particular patient, we see also Anderson lesion. We see also Romanus lesions. Here we see also anterior syndesmophytes with bridging of the vertebral bodies. The fatty deposition is very easy to assess because it has a typical location underneath the anterior longitudinal ligaments. So all this high signal intensity on T1 represents fatty replacement in the area where previous inflammation existed. We can have also both, as we saw with the sacroiliac joints. Here you see low T1, high on STER. This is the Romanus lesion, which is acute. And here we have low on T1 to high, high on T2, low on STER, and they are sclerotic on CT. Therefore, this is chronic osteitis. It's the shiny corners that we mentioned on plain films. Here I have a case for you. This is a 42 male patients, drug abuse in the history, there is increased CRP and the ESR, and you have to choose between infectious spondylodiscitis, axial spondyloarthropathy, and modic changes. Please vote. Okay, well done. This is the correct answer. This is axial spondyloarthropathy. In axial spondyloarthropathy, we may see sometimes increased CRP and ESR. This is within normal limits. And although there is a history of drug abuse, there is no indication on the MRI that we have infectious spondyloarthropathy. Can we go back to the images, please? Oh. We have even increased percentage of correct answers. So we see here that there is no infection without any disc involvement and without enhancement of the disc and without any irregularity of the end plate. We need to have these findings in order to suggest infection. On the other hand, modic changes occur usually in the lumbar spine, lower lumbar spine, and we do have significant dehydration and degeneration of the disc, whereas the patient may be asymptomatic. Here we have symptoms. We have a young guy, younger than 45, with all the findings suggesting a Romanus lesion and Anderson spondylodiscitis or aseptic spondylodiscitis. Okay, and the final topic for today is the mimickers, because in real life things are not so easy. You do not have always this florid, this bright bone marrow edema. You do not have always patients under 45. What about a patient with 53, has inflammatory back pain, has one bone marrow edema lesion definitely, and one borderline? What are you doing there? So sometimes we have to deal with these patients, and in some cases there are disorders like stress, injuries, infection, rarely, and perhaps variants in bone marrow which can interfere with the proper diagnosis, particularly if we have a lots of red marrow in young patients or bone marrow hyperplasia. Then it's very difficult to pick up the bone marrow edema. Here I have two cases. Stress fractures and insufficiency fractures are recognized more and more commonly now. Here is an osteoporotic lady, 64. Osteoporosis was known in the history, presents with pain. We see the typical location of the bone marrow edema in the sacral wings, and we see the bilateral also, and rather symmetrical appearance. In this context, the diagnosis is easy. In this younger lady, though, it was very difficult to assess what's going on here, since she was 38. Her husband, a baker, also was ill for a couple of months, and she did the whole job professionally, and in the end, she presented with fracture, which you see the typical craniocaudal orientation and anteroposterior orientation of the low signal intensity line, which represents a fracture. Infectious sacroiliitis can be suspected when there is florid edema and enhancement. Here you see that the bone marrow edema is extensive and unilateral. As we mentioned previously, unilateral and florid edema suggests infections. Almost always this is the correct diagnosis. There is also enhancement of this area. So in the spine we may have some pitfalls, for instance the well-known modic changes. Here you see in a macroscopic specimen that we have fatty infiltration at the end plates and in the marrow just beneath the end plates. This is the modic changes type 2. We may have also fatty islands or overuse enthesitis. For instance, in this patient, we have low T1, high T2, high stir. This is a rather unusual area for a modic change. Modic changes are expected here in the lower spine, but still we have a significant degeneration of this disc without any high signal in the disc. Therefore, it cannot be Anderson's lesion. So this is a typical difficult scenario that we have to discriminate between modic changes and Anderson lesions. So if we have more than 3 lesions in a young patient, not in the lower lumbar spine, without significant disc degeneration, this is probably going to turn out to be an Anderson lesion. Also, hemangiomas may show some findings which may represent, particularly if they are not very typical, may they look similar to the Romanus lesions. Also some fatty islands, which are very common in the spine. But infectious spondylodiscitis, I think it's quite easy to suggest because of the fluid enhancement of the intervertebral disc and, of course, of the clinical and laboratory findings which suggest the correct diagnosis. So the common clinical scenario that we have to deal with is a young patient, less than 45, with inflammatory back pain. That means 1 or 2 hours of stiffness and pain in the morning, lasting for more than 3 months. We have normal SI joints. We don't need to have again and again plain radiographs because they induce radiation. There is some radiation burden, and we don't have changes in between 5 years after the onset of symptoms. Therefore, in these patients, we have to go for MRI. We have to go for an early diagnosis of axial spondyloarthropathy because in these patients, the current treatment is going to be efficient. So the indications for MRI is to include or exclude the diagnosis. If we don't see bone marrow edema, the clinician might be wrong. To assess for severity of active inflammation, sometimes the clinicians need to change the treatment or increase the treatment. To assess response to treatment, we've seen a couple of examples. It's easy to assess the response to treatment by just evaluating the extent of bone marrow edema, and then to investigate possible complications or coexisting disorders. Don't forget, the ASAS criteria include only BME, bone marrow edema of the MRI of the sacroiliac joints. However, if we do see spinal lesions like Romanus or Anderson's, we say to we can write to the report that these are highly suggestive of axial spondyloarthropathy. We need to have 2 areas of bone marrow edema in order to fulfill the criteria of the ASAS for the diagnosis for axial spondyloarthropathy. Capsulitis, synovitis, or enthesitis without bone marrow edema should not be considered positive MR imaging findings. They can also be seen in overuse of the spine, in athletes, for instance. At coexistence of active and chronic lesions are considered a positive examination for a diagnosis for axial spondyloarthropathy. I wonder if we have time perhaps for one more case? Yes? So I know that all of you are quite familiar with the islands and Aegean Sea of Greece, but there is also beauty in the mountainous area. For instance, this is northwest. For those of you who are adventurous, this is a nice area for trekking, mountain trekking. So I hope with the cases I contributed to the fact that we look for what we know and we find what we are looking for, and therefore if we do not know what to look for in an MR for axial spondyloarthropathy, we will never find it. So let me show you a tricky case. Here we have a 19-year-old male with 3-month pains. So we have the criteria by ASAS, younger than 45, 3 months pain at least, and we have these MR images. Please vote. This is a case from real life, which is not always as the textbooks or the articles suggest. Okay, equally divided, but none has seen the hip enthesitis. Okay, the correct answer is the fourth one, actually, because we have all of the above, and I will tell you what I mean. Can we go back to the images? This is hip enthesitis. You see that in this young guy we have edema in the soft tissues in between the intermuscular fascia. Here you see extensive edema, which is also enhancing extensive edema with bone marrow edema in the hips. This is reactive to the enthesis, but we also have these tiny areas of bone marrow edema on both sides of the right sacroiliac joint. So in case that you are wondering, are these two tiny areas of bone marrow edema enough to establish a diagnosis of axial spondyloarthropathy? The answer is yes, because in this particular patient we do have also hip involvement. We have extensive enthesopathy, which is helpful in order to suggest the correct diagnosis. And this is perhaps a more difficult case because the edema is very tiny. Can you see any edema here at all? Perhaps a small area here and here. But we have extensive enthesopathy here in the gluteus tendon insertion. We have extensive edema of the gluteus muscle, edema in the superficial fascia here, enhancing also, as you see here. We have also intermuscular enthesopathy, and therefore extensive enthesopathy together with some tiny areas of bone marrow edema suggest the correct diagnosis. So this is a supporting finding. Thank you very much for your attention.
Thank you very much for this spectacular and very interesting lecture. Practice. Bueno, vamos a continuar con la próxima charla. Evaluación de la artritis por el doctor Rodríguez de Abreu en esta sesión de artropatías.